Right. Good afternoon, everybody. Thank you for joining us for today's Leaders Initiative seminar. My name is Stephanie, and I will be monitoring things here on the back end. When it comes time for our questions and discussion, please feel free to unmute yourself and turn your camera on for more active discussion. If you are unable to do that, you feel free to put questions and comments in the chat as well, and I will be monitoring those. Our next Leaders Initiative seminar will be December 15th. Dr. Frank Raven will be presenting Genetic Resilience to Alzheimer's Disease, Linking Sleep, Memory, and Brain Pathology. Towards the end of this event, I will be sending out a Qualtrics evaluation, so please fill out the evaluation so we can have a better idea of what sort of topics everyone's interested in learning more about. And with that, I will turn things over to Courtney for our introductions.
Great. Thanks so much, Stephanie, and thanks everyone for joining us today. We're so excited to welcome Dr. Shruti Mishra as our speaker for this month. Dr. Mishra is a tenure-track assistant professor within the Division of Neuroradiology in the Department of Radiology. Her research interests include validation of low-field MRI in neuroimaging and translation of quantitative MRI imaging biomarkers for brain health with focus on vascular contributions to cognitive impairment and dementia. With that, I'll turn it over to Dr. Mishra.
All right, thank you for that introduction. So the title of my talk is From Risk to Injury, Mechanistic Insights into Age and Vascular-Related White Matter Abnormalities with using diffusion-weighted MRI. I don't have any relevant disclosures. So cerebral, we know that the white matter is important when assessing for the presence of cerebral small vessel disease. Clinically, we grade cerebral small vessel disease by the degree of white matter lesions that we see on T2 weighted images. So this is most commonly flare. But other findings we also look for include presence of lacunar infarcts, microhemorrhages, and large perivascular spaces. But despite all of that, when it comes to quantification, the most common feature that we're often quantifying are these white matter lesions, which colloquially in the literature, people refer to as white matter hyperintensities. White matter hyperintensities, which in the remainder of my slides I'll be using the WMH short form, increase with cardiometabolic risk factors, and this has been shown most strongly with hypertension specifically. But we know that overall these white matter hyperintensities are non-specific. So we know, for example, from the Diane cohort that they also increase in Alzheimer's disease. We know that there is a certain number that they also increase with aging, even in cognitively normal individuals. And when severe, they're a poor predictor of cognitive impairment and overall represent a later stage of white matter injury. Importantly, we know that most patients with probable Alzheimer's dementia, from a clinical standpoint, have mixed pathology when they reach pathology, with the majority of patients having some vascular contribution. So in this study, in patients who had probable AD, the vast majority had mixed pathology, with vascular being a component in the majority of these patients. Here, other OD represented other degenerative components, which could have represented presence of Lewy bodies, TDP-43, or hippocampal sclerosis. So corpus callosum, the microstructure of the corpus callosum has been a possible imaging biomarker that people have evaluated for specifically quantifying vascular contributions in vivo. For example, in this study that looked at an association between vascular health, they basically combined various cardiometabolic risk factors into a cardiometabolic risk score and looked at, used a whole brain voxel-based morphometry approach using DTI measures as measures of microstructure. They found even when accounting for age, sex, education, global amyloid, and tau burden, that the association between vascular health and microstructure were seen dominantly in the corpus callosum, as well as some surrounding structures like the fornix and cingulum. Additionally, microstructure in the corpus callosum has been found to be significantly different in patients who have evidence of cerebral small vessel disease. In this particular study, they limited all of their participants had either moderate or severe white matter lesions based on a Physicus kind of grading score. And they found when they compared patients who had evidence of moderate or severe white matter lesions who were cognitively normal versus who had some cognitive impairment, when they looked at microstructure changes in white matter tracts, that the differences in microstructure localized to the corpus callosum, as evidenced by these areas that demonstrated that are red voxels in the expected area of like the genu and body in the kind of more anterior portion of the corpus callosum. And then microstructure in the genu of the corpus callosum. In this particular study, they were focusing on the measure of fractional anisotropy from DTI, that they found relates in a large community-based sample to various non-imaging indicators of vascular contributions as well, looking at plasma biomarkers, behavioral measures, gait, as well as various vascular risk factors. So hopefully I've convinced you that looking at the corpus callosum is important biologically for understanding vascular-related changes that occur. And so the objectives of this particular study was to look at to see what can biophysical modeling, or in other words, a more advanced measures of microstructure that we can derive from diffusion MRI, can that improve our understanding of age-related and vascular-related effects of microstructure changes in the corpus callosum in a cognitively normal cohort? And can some advanced measures potentially yield more sensitive biomarkers to early changes that are attributed to systemic vascular disease? And so in order to kind of really understand what some of these different diffusion models are telling us, I'm going to do a quick and dirty review of diffusion MRI. The caveats that I'm not a physicist, I'm a clinician, but this is sort of how I think about diffusion MRI and what we are, and I think what I think is the most important pieces when we're looking at these different models and what they tell us. So the goal of diffusion MRI is to get information about tissue microstructure, which we know occurs on the order of microns or tens of microns from an image that we're acquiring that has a much larger spatial resolution, right? Like on the order of 1 to 2 millimeters. And how can we get measurements like that? We make use of the principle of diffusion, which refers to the thermal motion of water molecules, which is also known as Brownian motion. Einstein developed the mathematic theory to explain Brownian motion, to model diffusion as a statistical random walk with a Gaussian distribution, and derived basically a formula for displacement, or the root mean square of the displacement for a particle as a function of the diffusivity d, as well as time, and this constant, which is determined by whether we're discussing 1D, 2D, or 3D displacement. In completely unhindered environments, we know that the diffusivity of water is around 3 microns squared per millisecond. Of course, we know in biological tissues, water is not completely unhindered, so we know the diffusivity is likely less than that. But at clinically applicable diffusion times on the order of 50 or 100 milliseconds, this allows us to measure displacement on the order of tens of microns. In MRI, we measure signal of hydrogen protons of water molecules, and diffusion MRI basically allows us to make use of these principles to get a measure of diffusivity. So diffusion MRI uses two gradients with strength G that's turned on for a little time, little delta, and a time in between these two gradients is defined by a large delta, and the actual strength of the gradient is defined by G. And in an MRI environment where there's a static magnetic field that allows for all protons to start with identically aligned spins, when we apply these two gradients that are separated by some time, we're able to differentiate protons which are freely moving, aka in an unhindered environment, compared to molecules that are not freely moving. And the diffusion weighting we define by this term, the B value. Once you can see a B, when the B is 0, in other words, when there's no diffusion weighting, you can see that water molecules, like for example, in the CSF, appear bright because there's no diffusion weighting, but as we apply at the higher B values where you have high levels of diffusion weighting, the voxels that appear bright are the ones that where they are in the most hindered environment. In this case, the high signal intensity you can see is in the highly ordered axons that are in the posterior limb of the internal capsule where the cortical spinal tract fibers run. The ultimate goal, so we acquire diffusion, we do our diffusion acquisition. The ultimate goal is to reduce our diffusion signal to quantifiable parameters that reflect microstructure that we can then obviously analyze and interpret to measure disease states. And there's various ways of basically going from our acquisition step to our parameter estimation step. And here, and the parameters that we derive really depend on whether we use like a signal-based representation or newer methods like biophysical modeling. So the modeling strategy for diffusion-weighted MRI can be really just sort of simplistically thought of or divided into two big buckets. The first broad umbrella are signal-based representation strategies where we're essentially trying to describe signal decay, or in other words, the signal decay that occurs when we acquire our diffusion sequence. Uh, um, how are basically based on applying formulas to that signal decay and deriving parameters from that. This is, in theory, applicable to any tissue type, and it's highly sensitive. But the downside is that this lacks specificity. So if you've heard of diffusion tensor imaging or diffusion kurtosis imaging, those are both signal-based representation strategies. Now, the second big kind of bucket of modeling strategies which people have now had increased interest in include biophysical modeling techniques. And here, by definition, you are making some assumptions a priori in the form of a simplified schematic of the tissue where the water is diffusing. And because there's an underlying assumption made about the tissue, the parameters that you're able to derive are, in theory, more specific to that tissue type. And there's a potential to yield parameters that actually characterize the microstructure. And the reason this is of interest is because then it can give us the ability to yield parameters that may be more biologically informative. But the downside is that they are highly dependent on assumptions. Because you are taking all of your diffusion signal data and like applying it to a model, there's a tendency to lose some of that information in the modeling, and they can be less lose some sensitivity, but gain specificity. So, diffusion tensor imaging is the quintessential signal-based representation strategy. It models molecular motion as one would expect for freely diffusing molecules obeying a Gaussian distribution. It's a valid assumption for freely diffusing molecules at sufficiently low B values. DTI makes the assumption that diffusion in biological tissues has directionality, or in other words, is anisotropic, and models that anisotropy using the shape of a 3D ellipsoid. So in order to describe an ellipsoid mathematically, one needs 6 unique values. Therefore, to acquire diffusion MRI data and perform a DTI-based representation, you need to acquire diffusion along a minimum of 6 gradient directions. And the 6 values, basically the 3 eigen values and 3 eigenvectors, are with the 3 eigen values, which are here defined by lambda, and the 3 vectors with v1, v2, v3. The parameters that we estimate from DTI are relatively easy to understand as they're directly derived from these eigenvalues. And the parameters that are most frequently reported in the literature include fractional anisotropy, where diminished FA is reflective of impaired microstructure. But we also get measures of mean diffusivity, which is essentially an average of the 3 eigenvalues. Axial diffusivity, it's the eigenvalue in the dominant diffusion direction. Radial is the average of the other 2 directions. Diffusion kurtosis is an attempt to account for non-Gaussian diffusion and has been postulated to be a measure of tissue heterogeneity. So in other words, I think I showed you the beginning part of this curve where if you were to model a log of your diffusion signal as a function of your b-value, you can see that a linear fit is pretty good up to about a b-value of 1000. But as you get to like higher levels of b-values, which again, remember this value reflects um, our degree of diffusion weighting, we know that at high B values, this starts to deviate from that linear fit. And it's been shown that at these higher B values, including basically fitting a kurtosis tensor, gives us a better fit to that signal. And so the kurtosis tensor has a much more complex morphology compared to, the diffusion tensor, which is relatively easy to understand. And being able in order to do a kurtosis fitting, you do require a little bit more complex diffusion data. So that includes data with higher B values and larger number of gradient directions. And we get scalar measures from the kurtosis tensor, such as mean kurtosis, axial kurtosis, and radial kurtosis. And as I mentioned, these are measures of tissue heterogeneity in that where higher kurtosis is reflective of water molecule diffusion that deviates from that Gaussian distribution, and has been shown to have maybe potential to improve estimation, for example, in gray matter, in areas where we know that DTI doesn't perform as well, for example, in gray matter and in areas of fiber crossings. But how does that differ from biophysical modeling techniques? So the basic principle of many of these advanced methods is that there are two effects that kind of contribute to the macroscopic voxel level diffusion signal. One is the microscopic diffusion process, which we refer to as the kernel. And the second is the mesoscopic sort of structure, which in the context of white matter is how bundles of axons are arranged within a voxel. This mesoscopic structure is reflected in the fiber orientation distribution function, which can be used for tractography, similar in techniques such as how we do with DTI when we're interested in doing tractography. And the kernel is the model that's really the biophysical model or what's happening at the microstructural level that's based on assumptions that we make about the tissue microstructure. There are many biophysical models, and there's kind of an alphabet soup of them described in the literature. Here I've listed some of the most common. Perhaps the most common in the context of like aging and dementia literature, if you've heard of one of these, probably the one you've heard of is NADI. But lately there's been kind of a thought like, how can we sort of create a unifying framework that takes what we've learned from all of these different biophysical models. And this unifying framework essentially is a proposed framework that is trying to unify many of these multi-compartment model-based strategies, which essentially, and people have referred to this as the standard model. And in this proposed framework, the assumptions that we make a priori about the structure is that within a voxel, you'll have multiple groups of axons that may be oriented in different directions. And within a given group of axons or in an elementary fiber fascicle, that your diffusion signal there is resultant from diffusion that's occurring in an intraaxonal space and diffusion signal that's occurring in the extraaxonal space. And from this, from basically using a ball and stick type model for the intraaxonal space, we can get parameters of intraaxonal volume fraction, or F, which is a measure of the axonal density, and the intraaxonal diffusivity, in other words, the diffusion signal within one of these axons, which is a measure of axonal integrity. In contrast, diffusion in the extraaxonal space can be divided into the diffusion signal that's occurring parallel to that dominant direction, axonal direction, and diffusion signal that's occurring perpendicular to. And people have shown in ex vivo mouse models with cuprizone therapy that the diffusion signal in the parallel direction may be very sensitive to acute demyelination and the associated neuroinflammatory process that occurs, and diffusion signal in the perpendicular direction may be reflective of the integrity of the myelin sheath, particularly in the setting of like more chronic demyelination. And so the goal of the next couple slides is to really provide a high-level justification for the biophysical model that we chose for this study. The intent of this talk is not to give you a full review of all of the different biophysical models and why and how they're different, but I really just wanted to highlight that many of the biophysical models are really derived from the standard model, except that with the exception of NODI, which includes a third compartment, and models CSF as a third compartment. But as you can see, many of these other models have the same sort of two-compartment model, but the primary difference between the standard model and some of these earlier models is that there are in the standard model, all of the diffusivities are unconstrained, versus in these earlier models, there one or more constraints were applied to the diffusivities in order to aid in parameter estimation. The standard model gets around this by using a priori priors, like in a Bayesian estimation type method, and uses a machine learning in order to get away from applying these constraints, and that way it allows us to actually estimate all of these different parameters, versus in these earlier models, of course, if you're making a constraint based on the diffusivity that decreases, it eliminates your ability to actually measure that particular parameter. And this is and the application of these constraints may not always be biologically valid. For example, well, like before I get to that, people have looked at simulated data from clinical diffusion MRI protocols. In this particular case, I think they use the diffusion MRI protocol that's used in the Human Connectome Project study, and they added noise, and they looked at parameter estimates that were yielded by the standard model compared to these earlier models, and found basically that the parameter estimates yielded by this model may be more valid than those from other models, just based on doing like simulated data. But furthermore, applying these diffusivity constraints may, affect our ability to, may not always be valid in certain in disease states. So this is an example of a stroke patient where you can see like a left middle cerebral artery distribution stroke. And for example, F is another word for the intraaxonal volume fraction. In the context of NODI, people sometimes use the term neurite density index to reflect that parameter. And you can see that both NODI and the spherical mean technique produced non-physical values for the intraaxonal volume fraction in the area of the infarct, suggesting that the assumptions that are particularly made in those different models may not be valid, in the case of ischemia. So that's, this is just to highlight that even though applying diffusivity constraints, while they help with parameter estimation and allows them to be more computationally feasible, making sort of an umbrella a constraint may or may not be valid in different disease states. So hopefully now I've convinced you that looking at microstructure in the corpus callosum is important, and the goal of this particular study was to see, can biophysical modeling using the state-of-the-art standard model approach that allows us to measure all these different compartment diffusivities, can that help us improve our understanding of age-related and vascular-related changes? With that, I will go to we'll go to the methods. So this study leverages participant data from our longitudinal ADRC cohort from the UMMAP study. We looked at only participants who were cognitively normal and without a dementia diagnosis, and limited ourselves to participants who had undergone an identical 3-shell diffusion MRI protocol. I'll go over that briefly in the next slide. We did compute like cardiometabolic condition scores, like a CMC score that was additive of the whole of all of these different vascular risk factors. Overall, we found in this particular cohort, we were limited basically by participants who had been imaged with this protocol up until my data pull, which I think it was around April 2024. So there were 112 participants that I pulled, and overall this was a pretty healthy cohort. So you can see that the overall cardiometabolic composite risk score was pretty low across the subjects. The cohort was mostly female. And I included Trails A and Trails B scores to show that there was reasonable variance in some of these measures, but overall, we didn't look at any neuropsych measures in this cohort because they were all cognitively normal. And then this is the race breakdown. And here I've shown a log of the white matter lesions that are in our cohort. And the big takeaway here is that overall, because our cohort was cognitively normal, they overall did skew to be kind of lower lesion volumes. We did actually eliminate this outlier because that was a segmentation error. But I just wanted to kind of bring up that we are looking at white matter hyperintensity lesion volumes, but overall our cohort skews kind of in the mild to moderate white matter hyperintensity volume range. All of our participants were scanned on a 3T scanner with a 32-channel head coil. So this is our diffusion MRI sequence was a 3-shell protocol. In other words, we had B values of 500, 1,000, and 3,000. We, of course, also use the FLAIR, the T2 weighted FLAIR sequence to quantify our white matter hyperintensity volumes, which we did with LSTAI. We also did our diffusion MRI processing as pre-processing, including kind of all of the relevant steps, and then did our multi-compartment parameter estimation, as well as both DTI and kurtosis fittings. This is an example of what our maps look like. So we had basically 4 parameters derived from DTI, our fractional anisotropy, mean diffusivity, axial and radial diffusivity from DTI. And then from kurtosis, we had mean kurtosis, axial and radial kurtosis. And then our 4 standard model parameters that we looked at were F. Again, this is a measure of the intraaxonal volume fraction, or in other words, axonal volume. Our DA is a measure of axonal integrity. And then our extraaxonal, perpendicular, and parallel diffusivities, as a reminder, are, we believe, measures to be sensitive to the myelin sheath, where extraaxonal perpendicular diffusivity we think is a measure of chronic demyelination, and this extraaxonal parallel diffusivity sensitive to more acute demyelination and neuroinflammation. For post-processing, we essentially, big picture, used the Johns Hopkins University atlas. It's a white matter atlas to derive regions of interest. And our 3 regions of interest were, we broke up the corpus callosum into the anterior portion, in other words, the genu, the body of the corpus callosum, and the splenium of the corpus callosum. We did all of our computation in subject space. So in other words, we took the ROIs from the template space and put them into subject space using the T1, and we aligned the diffusion to the subject T1 by using the B0 average image and brain extraction, and doing a combination of linear and nonlinear registration to register the subject space B0 to the T1 image. This yielded us average microstructure measures in the genu, body, and the splenium for all of our parameter measures. This included our 4 DTI measures, our 3 kurtosis measures, and our 4 standard model measures. So moving on to results. So we looked at age-related changes using each of these different measures. So here we've broken it up into the three anatomic regions: the genu, the body, and the splenium of the corpus callosum. The measures that are shown in green are our kurtosis measures. The ones in dark blue are the DTI measures. And then the ones in yellow are our standard model measures. And then where it appears grayed out is where, confidence interval for our standardized beta coefficient across to zero, in other words, are not significant. And then the ones that are not grayed out are statistically significant. We did apply an FDR correction by region to account for the multiple comparisons. And in all of our models, sex, education, and white matter lesion volume were included as covariates. So in our cognitively normal cohort, we're overall seeing that age-related microstructural changes were seen predominantly in the genu and the body and not in the splenium. As you can see, all of the splenium measures were not significant. This is overall consistent with prior literature, which suggests that age-related microstructural changes in the corpus callosum occur from an anterior to posterior direction, in an anterior to posterior gradient. And given that we have a cognitively normal cohort, it was not surprising that we only saw age-related changes in the more anterior portion of the corpus callosum. Of our standard model measures, we found that extraaxonal perpendicular diffusivity was really the most informative. It was the only measure significant in the genu, and then the intraaxonal integrity, in other words, DA, as well as extraaxonal perpendicular diffusivity, DPERP, were the two significant measures in the body of the corpus callosum. Taking all of our measures together, the extraaxonal perpendicular diffusivity in the body had the highest standardized beta coefficient in our relationship to age with all of these covariates. And overall, when you compare just including kurtosis above and beyond DTI, we found that kind of as a whole, kurtosis measures really were not as sensitive to aging compared to the DTI measures as a whole. As you can see, for example, in the genu, all four of the DTI measures were statistically significant versus only two of the three kurtosis measures. We also looked at microstructure predicting white matter hyperintensity volume. So this is, in other words, which one of how do these different measures compare when we're trying to predict degree of cerebral small vessel disease as kind of quantified by using white matter lesion volume as a surrogate for that. Here we included sex, education, and age as covariates. And again, kind of similar to the previous figure, the same kind of color scheme applies for the different models. And the ones that are grayed out are non-significant. Found that overall DTI metrics were the most sensitive to the degree of cerebral small vessel disease, particularly in the splenium, as only DTI measures were significant in predicting degree of white matter hyperintensity volume. And of the standard model measures, again, extraaxonal perpendicular diffusivity, in other words, that measure of myelination, of demyelination in the genu and body, were the most sensitive to degree of cerebral small vessel disease. We then did a set of mediation analyses, and here we were operating under, so knowing and understanding the fact that these standard model diffusion measures are more specific to, or potentially more specific to the underlying mechanistic change, can we use that to help us explain the underlying mechanism that occurs when we see help us explain the underlying mechanistic change between microstructure impairment that is measured by DTI and kurtosis, these signal-based measures, and white matter hyperintensity volume, again, using that as our surrogate for degree of cerebral small vessel disease. So for those who are kind of familiar with a mediation analysis, in other words, we're looking at our diffusion, our DTI and kurtosis measures. We're looking at specifically the ones that significantly predicted white matter lesion volume when we had age, sex, and education as covariates, and then looked at the standard model measures, limited ourselves to the standard model measures where there was a significant relationship between the DTI or kurtosis measure and the standard model measure, and then of those subset, which one of these had a significant mediation. Which of these yielded a significant mediation. And so this is a busy slide, but of the significant results, but I'm gonna walk you through it. Basically, we'll start with fractional anisotropy, where we saw a significant relationship in the mediation of extraaxonal perpendicular diffusivity. Again, that measure of myelination is a significant mediator of the relationship between fractional anisotropy and white matter lesion volumes. So, and this mediation, the proportion mediated was approximately 50% of the direct effect was explained through this mediation. So this result suggests that myelination may be an important mechanism that underlies the corpus callosum microstructure impairment that's inherent in FA when we are predicting degree of cerebral small vessel disease. Again, using that white matter lesion volume as a surrogate for that measure. And then looking at our kurtosis measures, so we had various kurtosis measures that had a statistically significant relationship in the genuine body with our lesion volumes. And we found across the board that basically extraaxonal perpendicular diffusivity was again a significant mediator of the relationship between the particular kurtosis measure, whether that's mean, radial, or axial kurtosis, and lesion volume, with approximately 30 to 50% of that direct effect explained through this mediation. Again, this result suggests that, kurtosis is meant to, or thought of, is to be a measure of tissue heterogeneity. And this result suggests that myelination, again, may be the important mechanism that's underlying that tissue heterogeneity reflected in impaired kurtosis when we're using that to predict cerebral small vessel disease. And then finally, this last relationship is somewhat interesting. With mean diffusivity and radial diffusivity, we had a significant mediation result with the intraaxonal diffusivity, which in other words, that DA, which reflects axonal integrity. However, if you see kind of looking at the actual total effect and direct effect results, you'll see that this is an example of an inconsistent mediation with a suppressive effect. And this result is very interesting because essentially, what do we know about mean diffusivity? Mean diffusivity is an average of the total diffusion in all directions, and we think that increasing mean diffusivity is a measure of diminished tissue integrity. And the relationship that there's increased MD correlates in the corpus callosum correlates with increasing white matter hyperintensity volume is consistent with the previous literature. So that's basically reflected in the total effect. But the suppressive effect is essentially is what we're seeing is that when we include the intraaxonal integrity or that DA measure in the model, our indirect of the beta coefficient actually goes up, and that results in this negative effect, or in other words, opposite signs of our total and of our direct and indirect effect. And this, of course, this is an interesting result. And my hypothesis for, what the biological mechanism that would explain this is that when elevated mean diffusivity is due to or routed through the intraaxonal compartment, this microstructural change may actually counteract the overall increase in white matter and hyperintensity volume. Or in other words, that the pattern of tissue injury that goes through the intraaxonal compartment may be distinct from those contributing to white matter lesion volume. And in summary, I think that is another way that's basically supporting the overall kind of big picture results that we're seeing that overall it's probably changes to the extraaxonal compartment, not the intraaxonal compartment that are in the corpus callosum that are underlying changes that we see sensitive to cerebral small vessel disease and probably supports that maybe myelination, maybe that the most important mechanistic contributor there. And so with that, so our conclusions preliminarily from the results that we've done so far, or the analyses we've done so far, suggest that in our cognitively normal cohort, we're seeing age-related microstructural changes in the corpus callosum, predominantly in the genu in the body, not in the splenium. Again, I think this is consistent with the existing literature. Microstructure changes in the corpus callosum predict the degree of cerebral small vessel disease as quantified by white matter hyperintensity volume, even in cognitively normal participants, which I think is important because the majority of the existing studies that have looked at this usually include cognitively impaired individuals in their cohort. Of the measures that were derived from biophysical modeling, the extraaxonal perpendicular diffusivity, in other words, this measure of the integrity of the myelin sheath or measure of demyelination, may be the most sensitive for age and vascular-related microstructure impairment in the corpus callosum. And biophysical modeling and our mediation analyses suggest that maybe, again, that demyelination, that the signal that's reflected in this extraaxonal perpendicular diffusivity may be the most important mechanism underlying diminished corpus callosum microstructure that's reflected in FA and in kurtosis measures as it relates to global cerebral small vessel disease, which again, we used white matter hyperintensity volume as a surrogate for. We're working on characterizing white matter hyperintensity specifically, like looking at these different measures in white matter lesions. And in a larger cohort, I hope to look at measures. I hope to look at some of these diffusion measures with serum measures of white matter injury. And I also hope to look at relationships between processing speed and executive function. Preliminarily, we haven't seen relationships, at least with Trails A and Trails B in our current cohort, but I do hope to look at this in a larger cohort, including participants with mild cognitive impairment in a subsequent study, which actually some of the things that I've mentioned in this slide are what I proposed in the NAC New Investigator Award Program grant. So I hope to do that in the next year or so. I would like to acknowledge my postdoc, Dr. Hani Karimi, and then previous members of my team, Trevor, who was a part of the ADRC and was instrumental in helping with diffusion processing, previous member of the neuroimaging core, and then a former student of mine who also helped with the white matter lesion segmentation, and then all of my colleagues in the neuroimaging core and beyond across the ADRC. And then I'd like to acknowledge I do get some partial funding support from the P30 grant. And then, like I mentioned, some of the future and ongoing work is going to be kind of funded, is partially funded by my recently funded NAC New Investigator Program grant. So I think that's all I have. I'm just going to briefly stop sharing just so I can see everyone, and I'm open to any questions. Sorry, it was total white matter hyperintensities. Sorry, Alyssa Torres, I saw your question. It was not limited to white matter hyperintensities in the corpus callosum. It was in all the white matter. So I was using the white matter hyperintensity volume the way we kind of do clinically, where it's like we use the total white matter hyperintensities in the white matter to get a sense of mild, moderate versus severe cerebral small vessel disease.
Shruti, Hank here. Thank you very much, and congratulations on the award. It's really wonderful. I was in another meeting, so I only heard the last 15 minutes of your talk.
Okay.
I apologize for that, but
no.
the bit that I heard included the conclusion slide.
Yeah.
And so there's some correlation between the microstructural changes in the corpus callosum and white matter, but there's also differences across the corpus callosum in terms of the extent of microstructural changes. To what extent do those differences across the corpus callosum track with regional hyperintensity or white matter abnormalities? We see some individuals who are normal, who have lots of posterior white matter changes, some who have more anterior white matter changes, an awful lot that's right in the middle. So do you have a sense for that?
Right now, I have not done any segmenting of white matter lesions. We're just using the total volume in the white matter, again, as I, kind of alluded to, as a surrogate to get as like a volumetric measurement of their degree of cerebral small vessel disease. I am kind of ongoing work. We are in this 122 participant sample. I mentioned earlier in my talk because they were all cognitively normal. They overall kind of skew from a clinically, if I were to grade their white matter lesion volumes, overall, this cohort was like mild to moderate in lesion volume. So they were kind of a healthy group. And so we are taking the 20 participants of the ones that we've already processed who have the greatest number of lesions. And we are doing a manual segmentation of anterior versus posterior white matter lesions. So we're doing that kind of ongoing plan for hopefully to get that wrapped up by the AAIC deadline is kind of the goal. But we are like actively looking at that.
Great, thank you.
Go ahead, Voiko. I see your hand.
Excellent talk, excellent talk. And I would like just to continue what Dr. Paulson said, but much more in terms of the differences in the body of corpus callosum. If I remember in the past, there was a lot of talk, the difference between males and females in isthmus, because, 20, 30 years ago, corpus callosum was very much related to the hemispheric asymmetry. Did you have a chance to look in your sample if in the isthmus or in any other part of corpus callosum there were some sex differences?
So we did look at sex differences in the three segmented regions of our corpus callosum. It was not we didn't see sex differences in any of the microstructure measures in the genu body or splenium. But to answer your specific question, in the atlas that I used for segmentation, really the isthmus is kind of lumped into the body of the corpus callosum. So we have not specifically looked at the isthmus. I know there are other ways of looking at it. I think the reason I didn't go about that is because I think it can be a little bit tough using any kind of automated method to really decide where does the isthmus start and end, just in terms of to do that. So I haven't looked at that specifically, but thank you for informing me of that sex difference specifically in the isthmus, and maybe we can kind of try and elucidate that in a using a different segmentation method. Oh, and then I saw another question. Would it be worthwhile to look at deep versus periventricular white matter hyperintensities? Yeah, absolutely. I'm actually, if for any of them, you people, anyone on the call who is, we're in our ongoing work where we're looking at, I actually did propose this in the NAC grant to look at deep versus ventricular white matter lesions. But the problem that I'm running into, which I've discussed a little bit with Norman. I don't know if maybe he logged off. But oh no, I see Norman's still there. But we've discussed this where it's just like there's not really great like automated methods, I feel. And so that's why we are going to, in our kind of limited subsample for our preliminary data, we are gonna, when we do manual segmentation, my goal is to look at anterior versus posterior periventricular, because that's what people have described as maybe the posterior periventricular more specific to amyloid-related pathology. Maybe it's Wallerian degeneration downstream of like temporal lobe cortical changes. And then also look at deep versus periventricular. It's just that when you actually, like when you're looking at things clinically, you can be like, okay, yeah, you can kind of get a gestalt. When you're trying to quantify, it's like, where do I draw the line versus deep versus periventricular? I'm trying to figure out a good like method to do that. Anyway,
Maybe I can add a little to
yeah.
that. Sorry, my camera is just not working right now. Um, yeah, so the big problem we have is once people have more white matter hyperintensities, they merge. So the periventricular branch out and eventually become deep white matter and connect to. So drawing the boundary is really, really difficult.
Yeah. Anyways, it's one of those like I propose some of these analyses now that I'm trying to do them. I'm like, dang, like it's tough to actually to really define it in a reproducible way. And so we're trying to figure that out. To also include physical activity. Yeah, that is a great idea. Do we have a measure like that, like some sort of aggregate measure of that in our sample? Maybe, I don't know. Well, if there is, maybe I'll just maybe I will email you, Alyssa, out and to get your thoughts on how we could potentially include that. Okay. All right, in UDS4 anthro. Okay, so yeah, this is why presenting in this kind of format is really informative because I'm sort of in my little imaging world bubble and I didn't kind of know about
Yeah, I don't think up until UDS4 we had much on that information. So I think that this
okay,
would be a good thing to be thinking about going forward for sure.
forward. Okay. All right. Well, I guess if that's all the questions, I really
Can
appreciate
I
oh yeah,
can I
sorry.
ask one more question?
Yeah, of course.
Sorry. Okay, so my question is so it's very basic. It's a question, a relationship between your signal and the ground truth. As you have indicated, there is a great heterogeneity of axons and myelination across the corpus callosum, smaller one to bigger one, or faster one, and sluggish one, not to mention that there is somewhere around 20% of axons which are not myelinated. So I guess the signal you are analyzing is primarily related to the big axons with a lot of myelination. Is that correct?
Yes. Yes, the model does sort of uh overall I think is probably most valid in a in big white matter tract regions. And that was one of the reasons that I started with the corpus callosum using this method, because then you don't have to worry about crossing fibers and other things where, things get a little bit more dicey with diffusion. But yes, I do. I think that probably we are not I don't think we're picking we probably are not picking up signal in non-myelinated axons.
Do you have any idea what are those sluggish, non-myelinated axons doing over there?
I think at least in this particular, I think that's a good point that whatever signal that might be attributed to that is probably being lumped into our intraxonal compartment. But no, I don't know. That's something that in terms of but I'm not like an expert on everything that's been published on corpus callosum, from a pathologic standpoint. So, but no, I don't have a good answer to your question. But I think that
Thank you.
but probably we are not picking up that signal using this model just based on the assumptions of the model.
Thank you.
Yeah.
Any other questions or comments before we close things out for today?
All right. Thanks
All
so much.
right. Yeah. Thank you so much for coming today. And mark your calendars. December 15th will be our next Leaders Initiative talk. Thank you, Shruti. That was a wonderful talk today. Very informative. And please take the time to fill out the Qualtrics evaluation. I will be sending a follow-up email with all of those links as well today. All right. Have a good lunch, everyone.
Take care.